And for the next session, the chairperson is Dr. Vikram Bhatia, Dr. Lalit Shimpi, Dr. Mukesh Kalla, and Dr. B.D. Goswami. I request chairperson to start the proceeding. Thank you.
Good afternoon, my friends. Today we have got 3 lectures on this session. The first one is the pancreatic cyst neoplasm, US guided sampling and the technique. Dr. Siu Po Yang, he is the chief of the endoscopy division at the National Taiwan University. Dr. Wang, please.
Thanks, Chairman. First, I thanks Dr. Puri is inviting me to join this meeting. Today, my talk is pancreatic neoplasm, US guided sampling and the technique. And as you know, the frequency of incidental diagnosis of pancreatic tumor continue to increase, and with the widespread use of cross-section imaging. And it is very important to describe the various different pancreatic tumor because they are with various prognosis and therapy. Among them, the mucinous severity are always pre-malignant or malignant, and surgical resection is generally recommended. And for the non-mucinous severity, are with very low malignant potential and always benign. And there is a wide spectrum of pathology of the pancreatic tumor according to the WHO criteria. However, US approach is to determine mucinous, non-mucinous, benign, or malignant. And US diagnosis of pancreatic neoplasm, including the imaging evaluation alone, also CT3 analysis and tissue acquisition. And the image evaluation of pancreatic tumor, including the pancreas parenchyma, ductal structure, acidic wall, acidic content, and others, including the metastasis. This picture shows the US image of serous cystic adenoma, including the microcystic type, macrocytic type, and mixed type. And this is solid-like mucin serous cystic adenoma. After the contrast enhanced, you can see a lot of microcytic component. And this video shows the main pancreatic type IPMN, a lot of solid part in the main pancreatic duct. And this is a branching type IPMN. And this simple cyst, but mural nodule in the cyst is MCN with a nodule. And some tumor with a generated part will like a cystic tumor, for example, like a solid acute papillary neoplasm. And also we have a cystic neuroendocrine tumor and necrotic pancreatic cancer. There's a lot of strategy for the management of the pancreatic tumor according to the morphology of the pancreatic tumor. However, US morphology alone for differentiating between the mucinous and non-mucinous tumor, the overall accuracy is low. So US diagnosis of pancreatic tumor with US imaging evaluation alone is not give a very good prediction. So maybe we have to use the US guided sampling. And why US guided sampling? Because approximately 13 to 20% of resect cysts are benign. And there are also some studies show US detect epithelial nodule with higher sensitivity and specificity. However, most echogenic lesion detected in cyst by US are mucus. Another study also showed the attended city wall histology is more predictive of malignant potential compared to cyst morphology alone. So we had to perform the US guided sampling for the the higher accuracy of diagnosis. The US guided sampling, including the free aspiration and also tissue acquisition. And the sampling, before the sampling, careful history taking and physical examination, review all the previous available image study to understanding the orientation of cyst related to the stomach and the duodenum, and correct if there any bleeding tendency. Antibiotic is very important for before immediately following the US FNA. The step of US sampling in our unit, we use the linear echo endoscope, usually with contrast wave before the puncture. And we use a 22 to 19 gauge needle for puncture. After the puncture through the wall, place the tip at the center of the cyst or largest cyst part of if the pancreatic tumor with multiple cyst component. After advancing needle into the cyst, remove the stylet and the suction is applied with 10 to 20 cc syringe. The needle is moved to and fro within the cyst to facilitate the fluid removal. And we will aspirate some cyst fluid first, then perform the transneedle biopsy or puncture over the wall or mural nodule. Then aspirate all the CT free. All the procedure was with one puncture. And then we throw the needle and check the bleeding. We will check the aspirate with the stream sign, if possible, the on-site cytology. Even though we will prepare the cytology smear by ourselves and make a tentative cytological diagnosis. And we will send the fluid for biochemistry, tumor marker, and the cytology. Why we use the contrast US before the puncture? As like this case, there are some solid part, mural nodule on the wall. After injection, the pseudocyst, 40 seconds, 1 minute, 2 minutes, the mural nodule did not show enhancement, so it's a pseudocyst. And in this CT tumor, there are some echogenic part on the septum. However, after the contrast, there are no enhancement. And in the other hand, is a viable tissue, like a tumor, there were enhancement after the contrast enhanced. That's the place we have to take the tissue sampling. This is a very interesting case. We perform this referral for US FNA because the pancreatic tumor considered is MCN with mural nodule. But after the contrast enhanced US, he showed hyper enhancement. So we think it maybe is a cystic neuroendocrine tumor. So we changed the US FN needle to FNB needle. And then the pathology turned to be cystic neuroendocrine tumor G2. And the who should be puncture? We have a Sendai and consensus. We have Fukuoka consensus. We have AGA guideline. So AGA guideline suggests pancreases with at least 2 high-risk features, like size more than 3, dynamic pancreatic duct, and the presence of associated solid components should be examined with FNA. Furthermore, if the significant change in the cyst, including the development of solid component size, increasing size of pancreatic duct or diameter more than 3 centimeters, they are also indicated for US FNA. So the ESFF sampling, including the fluid aspiration and the tissue acquisition. About the fluid aspiration, what is the size of cyst for US FNA? In one study, he thinks 1 centimeter of cyst is possible to test at least one variable in 75% of cases. Italy Society suggests 1.5 was the minimum required to obtain fluid at least one check-in. And the US guided fluid aspiration, we will check the color, viscosity, and we send the aspirate to biochemistry, including the amylase lipase level, tumor marker, CA and CA99, and also fluid-based cytology. This slide shows the transparent clear aspirate is a series of mucus, and the pseudocyst and the pseudopapilla will be deep brownish and like all blood. And the screening sign is very important for diagnosis of mucinous neoplasm. Screening sign is the most informative, and screening length more than 3.5 millimeter indicate the mucinous cyst. There are one study, screening sign plus CEA concentration can make the diagnostic accuracy improve up to near 90%. So the aspect analysis including the biochemistry, tumor marker, and the autocytology analysis, and it's possible to identify the identification of malignancy. However, cytology analysis, the sensitivity is very low. There are one study show the CEA is high in mucinous cystic adenoma, and very important study, they show the CD3 cover value 192 for differentiating the mucinous and the non-mucinous cystic lesion. They also find CEA level is significantly greater than the accuracy for US morphology alone or cytology. There are no combination tests. They provide greater accuracy than CEA level alone. This table shows the CEA level in cyst group is better than other tumor marker. And this our case is MCM with nodules, and the CD3 CEA level is more than 3,000. And this table shows the free cytology for diagnosis of mucinous sensitivity is quite low, and accuracy also very low. As you know, now the CD3 DNA, the molecular analysis is very popular, can improve the limitation of diagnostic accuracy by using cytology of chemical and the tumor marker analysis alone. However, not every institute have available this test, and the cost is high, but it's very promising in the near future. According to ASG guideline, they suggest sampling, US guided sampling for biochemistry analysis plus cytopathology examination. And they also recommended if the aspirate is small, CEA is the first analysis choice. About the tissue acquisition, ASG suggests perform a direct wall puncture or KRAS mutation analysis if the aspirate is too scanty for assessment of CEA concentration. US tissue acquisition will target on the hypoechoic mass of the cyst or pancreatic duct, and also popular projection mirror nodule within the cyst. Sometimes the cyst wall or subtension intraductal papillary lesion if the main pancreatic duct is sufficient to dilate it. And also some studies show the targeted FNA before cyst drainage is better, because after drainage the fluid, it is difficult in discriminating target lesion from surrounding normal pancreatic parenchyma. And this is our case after the contrast enhancer study. We puncture the enhancer site and get the tissue. Now, how about the on-site cytology? There are studies show there is this concordance rate of up to 26% between the on-site assessment and the final core biopsy finding. And some targeted city wall puncture and aspiration is suggest, because you can have the less inadequate specimen, increase the diagnostic year, and also provide a substantially increment year to the diagnosis of mucinous neoplasm compared with other checking examination. Another is US guided through the needle forceps biopsy, and the mini biopsy process introduced through a 19-gauge needle allowed us the tissue sampling and the pancreas CD3 acquisition at the same time. And the diagnosis accuracy has been reported very high compared with the US FNA. And in this study, he showed a higher clinical success, and the mucinous diagnosis, even the CEA level is low. This is our case. After the 19 gauge needle, we put the micro forceps and tuck on the enhanced solid part. And the sample can be up to 2 millimeter. And the cytology smear can show the adequate tissue for diagnosis. This is another one. We also, after the 19 gauge, we put the micro forceps and biopsy the solid part of the tumor. And we make the on-site cytology smear, and the specimen is more than 2 millimeter, and the quality of cytology smear is good. The system review, they include the 8 qualified study, and the pool technique success was over 90, and the adequate specimens was over 80%, and the adverse event was reported to 10%. And one issue is pathology interpretation. Because the specimen taken by US FNA cytology or biopsy, the specimen is very small. Result is low cellularity. And the cytology pathology smear preparation and interpretation is usually performed by different people. And pathologists also require time and experience to adjust to the relative post-cellular smear for US FNA specimen. This very small tissue specimen is taken by transneedle biopsy. Is much smaller than usual, and attention must be paid in the handling of such sample. So Dr. Ripper Corin have suggest for the transneedle biopsy specimen handling to reduce the risk of losing material. They place the sample between the 2 color paper disc and then into the gauze envelope. And the paper tissue complex normally proceed for paraffin inclusion. And the small white sample will be easily recognized during the micro tones section. They also suggest the including of each specimen in a single paraffin block to solve the possibility of waste of the tissue. A very good idea. And about the complication of, they are including the infection, pancreatitis, and the very important intracetic hemorrhage have been reported occurring 1.3 to 6% of patients. A study showed the complication compared with the solid tumor. The complication rate is similar. And however, another study showed the higher incidence of infection and the hemorrhage complication for the USFNA for pancreatic region. And recently, the intrahepatic bleeding rate was reported to around 60, and but it's cell limited and not significant. This is our case. After the puncture, it showed the bleeding, and is after the 6 minutes, we will show the bleeding. So my conclusion is US sampling is direct CT wall histology is more predictive of malignant potential, and can confidentially diagnose benign lesion such as serous adenoma, subsequently exclude them from further surveillance, and also exclude patients from unnecessary surgical procedure. And the complication rate is low. And the most important is antibiotics before aspiration is 1 pass and the complete aspiration. And also communicate with your pathology for the result of the USFA procedure. Thank you for your attention.
Thank you, Dr. Wang,
for your excellent presentation. Is on live? Hello. Yeah, any questions from the co-chairpersons?
Dr. Wang, this is Dr. Lalit Shimpi. So this Moray forceps seems to be very interesting kind of accessory. Is it available commercially? Do you think that in future we might be using this through the 19 gauge needle as a substitute for taking biopsies or US FNB if it is increasing yield? Any studies on using it in usual kind of biopsies, UFNA biopsy, rather than just in cystic tumors?
Yeah. Do you mean the micro forceps?
Yes, the
Yeah.
Moray forceps.
Yeah, I think this forceps is quite good for the biopsy over the cyst or mural nodule, because some solid part is especially papillary projection when we aspirate by the routine needle. The material will free from the needle and not easy to attack the tissue. But they still have some problem between our unit and pathology, because the biopsy material is very small. So we had to communicate with pathologists and make some procedure to keep the material. I think if we can, the pathology can handle the small specimen, and the technique is feasible for everybody. I think it's, in my opinion, is better than a needle aspiration. Yeah.
Thank you.
Dr.
Thank you.
Wong? Dr. Wong?
Yeah, Bikram.
Yes,
Yeah.
Dr. Vikram Bhatia here.
Yeah, hello.
Very nice talk. I have only one small question before you go. What is your protocol for processing the cytology, the cyst fluid cytology in your unit? When we remove
Okay.
the cyst fluid, the cytology, how do you do?
Yeah. We have separated two part, and the because fluid based cytology usually very low yield rate. But we try to make the smear in the endoscope room, and the solid part we will make the smear by ourselves. And if the cytologist can come, we will discuss with them. If no, we will make the tentative diagnosis, because we learn from the cytology every time, case and experience. Nowadays, we can diagnose the tissue acquisition cytology smear very comfortably. We can know the cellularity is okay or not. We can see the cell is abnormal or not abnormal, and maybe sometimes we can know the result for like adenocarcinoma, for the pseudopapillary, pseudopapillary neoplasm here, very characteristic picture. So if you not get the big tissue, only fluid cytology, maybe in the near future we have to proceed to have some molecular diagnosis. This is not available in my hospital. We try to contact with somebody when the tissue is, I think, is inadequate for the smear cytologist. Yeah.
Thank you, Dr. Wong.
Wang. We can invite the next speaker, Vikram.
Yes.
No, thank you.
The next speaker, everybody knows him in India, is Dr. Dong Wong Seo from Seoul, Korea. He is very popular in India. Everybody knows him, loves him, and would love to hear from him. He is speaking on a very important topic, pancreatic cyst ablation. He has one of the world's largest and most prolonged experience in the cyst ablation work. Dr. Dong Wong Seo, please.
Thank you, Bikram Bhatia. It's my real pleasure to have the chance to share my experience of pancreatic cyst ablation with everybody here. My special appreciation goes to Dr. Rajesh Puri and all the organizing team members. I'm going to start my slide show now. Can you see my slide?
Yes, we can. Very nice. Please go.
Summit this year again. I'm going to touch the topic, how I do it, pancreatic cyst ablation. These are the areas I'm going to cover. As an introduction, I am going to briefly touch the history and our study. The first use-guided therapy of pancreatic cyst was tried by a Harvard group, The Professor Bill Brugge initially reported the result in GIE 2005. They included 25 patients and escalated the dose of ethanol from 5 to 80%. It was because of ILB issues. And then they observed the complete resolution of cyst in about 35% of the patients. Inspired by that study, our group also started US-guided therapy of pancreatic cystic tumor and reported the result in GIE 2008. When it included 14 cases, the complete resolution was observed in 11 patients, and partial resolution in 2 cases, and a persistent cyst in 1 case. The complete resolution rate was almost 78%. It is twice higher than the Bill Brugge's report. So we were very much encouraged by this result, and we continuously developed this technique and refined our technology. From previous reports, we can see if we use this technology wisely, then it can be very helpful for the suffering patients. But the indication is very important. Not all the patients shows complete resolution. When we first started the US-guided ablation therapy, we applied very strict inclusion criteria. It is because we did not know what will happen after US-guided ablation, the efficacy and the complication profiles, etc. So we included only unilocular or oligolocular cystic tumor, size ranging from 2 to 5 cm. It is not based on MCN or SCN IPMN like true histology. We don't know true histology at the time of ablation. Only presumed diagnosis is available. And exclusion criteria are as follows. Based on clinical history and the image findings, if pseudocyst is suspected or serous cyst adenoma is suspected, then we exclude it. And the overt cyst adenocarcinoma or IPMN showing clear communication with main pancreatic ducts were all excluded from this study. But after initial study, we tried to expand our inclusion, and we targeted multiple septated cystic tumors of the pancreas, and we reported the results in Scandinavian Journal of Gastroenterology 2009. It was effective. In the year 2011, we tried to analyze our long-term follow-up data and published it to Gastroenterology. And these are our group's recommended indications. Unilocular or oligolocular cystic tumors are the best target, and the size ranging from 2 to 6 cm would be good, but it is not absolute. We can target even larger cystic tumors. Presumed diagnosis of MCN or SCN or indeterminate cyst may be a good target, but a cyst should not have clear communication with the MPD and without evidence of malignancy. Let me move on to technical details of US-guided cyst ablation. This video shows the techniques of US-guided ablation of pancreatic cystic tumor. If there is any growing cystic tumor in the pancreas, we can use EUS for the delineation of the lesion. Under linear EUS view, we can identify the cyst and inject the needle and aspirate the cystic fluid. Aspiration, we can inject ethanol again and re-aspirate and re-inject. This is called ethanol lavage. After lavage, if it is necessary, we can instillate small amount of paclitaxel inside the tumor. There are several technical variations. Classic technique is ethanol lavage, but we can modify it as ethanol retention therapy, while we can combine chemotherapeutic agent injections with paclitaxel injection. This video shows the technique of ethanol lavage. Delineate the cystic tumor on the US view and insert the needle and aspirate the cystic fluid. As you see here, if we aspirate the cystic fluid, then the cystic cavity is collapsing and the nearby pancreatic tissue or vessel is getting closer. So need to keep the needle inside the cystic cavity. Is very important. After cystic fluid aspiration, we can inject ethanol into the cystic cavity. Now we can see the cavity size is increasing now. This the amount of ethanol is generally same as the amount of aspirated fluid. After ethanol injection, we can do re-aspiration. Now the cyst is collapsing, and this procedure can be repeated 3 or 4 times. And this technique is called ethanol lavage. This is previous lavage case, a lavage case before treatment. T-scan was acquired in the year 2005, January 10th. Before treatment, we can see 3.4 cm cystic tumor. This is CT scan 3 months after US guided therapy. We can see complete disappearance of cystic tumor. Classic ethanol lavage means repeated injection and re-aspiration of fluid. It is generally good for small size, relatively small sized cysts, unilocular or bilocular cysts. We can avoid any leakage of ethanol because there is only one time of needle insertion into the cystic cavity. This is a large cystic tumor in the tail of the pancreas. Upon use, we can see some septations, and the cyst wall is relatively thick. I used 22 gauge needle to aspirate the cystic fluid. This is EUS view. Before needle insertion, you are generally applying Doppler to avoid any intervening vessel. After needle insertion, we aspirate the cystic fluid, and this is the color of aspirate. And then we injected 100% pure ethanol inside the cystic cavity. You can see echogenic jet going inside the cyst. If there is non-communicating locule, we can change the needle direction and puncture that locule and aspirate and inject ethanol. After enough retention time, we did the aspiration of cystic fluid and then instillated a small amount of paclitaxel. This is variation of lavage. When the cystic fluid amount is large, we are using ethanol retention therapy instead of ethanol lavage. Ethanol retention therapy can give longer retention time after ethanol injection. We are rotating the patient, supine 5 minutes, left lateral decubitus 5 minutes, prone 5 minutes, and right lateral decubitus 5 minutes after ethanol injection. Can give better contact of ethanol to the lining epithelium. Generally, 1 or 2 rotations are required, and this means 20 to 40 minutes of retention time. It is good for large cysts or multilocular cysts. And when it is necessary, we can combine paclitaxel injection. Let me move on the last part, the result of EUS-guided cyst ablation. This is a 30-year-old female patient, size-growing cyst in the body of the pancreas, and it caused the compressive symptom, and the upstream MPD is showing dilation. This is at the time of EUS-guided aspiration. The size was 3.7 cm, and the aspirate color was a dark brown color, and the CA very low, and amylase was 101 millimeters. Because of growing size and MPD compression, we decided to treat this case by US guidance. This is first ethanol injection and reaspiration, second time of ethanol injection and reaspiration, the third time ethanol injection and reaspiration. We did ethanol lavage 3 times. This is 2 months after CT scan. We cannot identify cystic tumor here. And this is 1.5 years later. Still, we cannot see any cystic tumor in the body. And the dilated MPD shows normal caliber now. So it is quite successful treatment. This is another case, 42-year-old female patient showing cystic tumor in the body of the pancreas, and shows the mural nodule and the daughter cyst here. 4 months after treatment, the cyst size became very small like this. And this is 1 year later, and this is 2 years later. We cannot identify any cystic tumor in this case, complete resolution case. We analyzed the long-term outcome after US-guided ethanol ablation of pancreatic cystic tumor and reported the results in endoscopy 2017. We did ablation in 164 cases, but among them 6 patients lost follow-up. And follow-up was possible in 158 cases, and complete resolution was observed in 114 cases, and partial response or persistent cyst was observed in 44 cases. Not all the case shows good response. This is one of recur case. At the time of initial EUS, we can see septated cystic tumor, but we treated this case under US guidance. 6 months after CT scan shows near complete resolution. However, 1 year after CT scan shows size regrowth, so we sent this patient to surgery. This is surgically resected specimen. Pathologically, in most of the locules, lining epithelium was disappeared. Only subepithelial fibrous tissue were exposed. But in some locules, there was atrophic mucosa and remnant mucinous adenoma. So initial good response was because of most of the lining epithelium was ablated by US-guided ethanol lavage. But if there is remaining adenomatous tissue over the period of time, the tissue will grow continuously. So later, it can show size regrowth after initial good response. There can be some procedure-related complications. This is acute pancreatitis case after US-guided ablation. And this is splenic vein thrombosis case. The most serious complication we experienced was main portal vein thrombosis. And this was the case. The cystic tumor was located very closely to the main portal vein. After 2 times of therapy, the cyst became a little bit smaller, but here we can see main portal vein thrombosis. So we sent this patient to surgery, and this is a pathology specimen, and we can see most of the lining epithelium shows atrophic changes or denudation, but because of injected ethanol and paclitaxel, it created main portal vein inflammation and thrombosis. These are list of complications: pancreatitis, portal vein thrombosis, infections, pancreatic duct leakage, fistula formation, and intracystic hemorrhage. Some doctors argued the durability of initial response. Yes, morphologically initial CR is possible, but is there any chance of recurrence of the tumor? So we analyzed our data. This graph shows clearly once complete resolution was achieved.
So is Dr. Don One CEO is online? Dr. Don One?
Yes, I'm here. I'm very sorry. My notebook, I'm outside of my hospital and my house.
So how many
And-
slides left, Dr. Donvan? How many slides left?
No, this is just the last one.
So can you speak without that so we can conclude?
Okay. So when we checked the recurrence rate, is once complete resolution was achieved, just 1.7% showed recurrence, even after 10-year follow-up. So we think this EUS guided cyst ablation therapy can be a very good option for those patients with pancreatic cystic tumor, but careful patient selection and tailored intervention is necessary because we want to avoid unwanted complication, and also we want to increase the treatment efficacy. Thank you very much.
Thank you, Dr. Dongwon. And that was a very nice lecture as always. And
I'm very sorry for notebook problem.
No. It was a very nice lecture. We heard it very well. I have only one small question, in fact, two small questions. What is your view about placing a pancreatic duct stent before putting in ethanol? Number one. Number two, have you thought of contrast EUS to see the viability of the remaining cyst after ethanol lavage?
Okay. The first question, pancreatic duct stenting, I think it's a good strategy when we are targeting cystic tumor showing communication with the main pancreatic duct. In those cases, if we inject ethanol, and there is the risk of leakage of the ethanol into the main duct and causing pancreatitis. So when we are targeting IPMN case, we do insert, especially IPMN case, which is located in the head or body, the distal part of the pancreas, I mean downstream side of the pancreas. I try to insert pancreatic stent before going to do cyst ablation. And the contrast enhanced EUS, generally good for solid tumor management like neuroendocrine tumor or insulinoma SPN case, because if you ablate it by ethanol or RFA, the contrast enhancement is not there anymore. Typically, these lesions show very strong arterial enhancement when we inject contrast. But when it goes to the cystic tumor, I'm not frequently using contrast-enhanced EUS, but in case of serous cystic tumor, the septum, when we inject contrast, the septum shows arterial enhancement. So we can see the septum very clearly. So after therapy, we may apply this, but that's only for microcystic tumor. Microcystic honeycomb time shows very strong arterial enhancement. But when the lesion is olivolular or unilocular cystic tumor, I'm not sure whether contrast-enhanced EUS will be very helpful. But in terms of the mural nodule viability, we can use that after cyst ablation. If the mural nodule is effectively ablated, there will be no contrast enhancement anymore.
Thank you, Dr. Dongwon. Very clear as always. Any other questions from the panelists? Thank you. Any other question from the panelists? Rajesh, should we continue? Should we move on?
Move on, just to stick on the time so we can move on to the next lecture.
Thank you.
Thank you,
Thank you, Dr. Donwan Seo. Thank you.
Thank you.
Dr. Lalit, invite. Dr. Lalit. So the next speaker is Dr. Lawrence. We all know him, everybody knows him, and he'll be speaking on something he has devoted so much time and personal effort on EUS training, standard methods to assess competence. Dr. Lawrence, please.
Thanks a lot, Vikram, for your kind introduction, and also thanks, Rajesh, for this, I think, this privilege to be able to talk to you. Okay, so I'm going to actually play the pre-recorded video, and which was actually unfortunately done a bit longer than it was 18 minutes. So I'll try to cut short the last part in order to finish on time. So let me just start the video. So this is really something that I think is important. Unfortunately, including myself, we haven't been able to do as well. So maybe we can all learn from this particular talk. Okay, so this is on EOS training and how we can standardize method to assess competency.
Good afternoon, everyone. I'm Lawrence Ho from the National University of Singapore. It is my pleasure today to talk to you during this occasion of the Indian EOS Summit on this topic of EOS training. I'd like to actually specifically speak about how we can standardize method to assess competency. As you know, I think after a workshop, we generally would like to actually do a feedback on how effective our workshop is. And this sort of feedback form is commonly done. And we want to find out whether our workshop is useful and beneficial. However, this sort of feedback is often too subjective and is not evidence-based in terms of assessment on the trainees' competency. And this is why we need other methods for us to be a bit better in assessing how good, how competent our trainees is after a particular training program or after a particular workshop. And I'd like to spend a bit of time talking about these two methods. One is the so-called procedural-based thresholds, and the other one is the more objective competency-based assessment. To do that, I think this particular concept of procedural-based threshold is actually quite commonly employed. Essentially, if you look at a particular, I think, learning curve of a trainee, okay, and this is actually quite common. And trainee goes through a slow beginning and then a faster sort of acceleration of their training learning curve, and before they actually become more proficient, where the learning curve slows down. So I think the so-called threshold number is actually defined based on statistically significant difference, okay, in the training procedure, in a trainee performance along this particular learning curve. So this is actually the point where the trainee is actually considered to be competent. So different societies have actually come up with their own so-called recommended numbers to define the thresholds of number of procedures. So if you look at ASGE, BSG, as well as a survey conducted many years ago among fellows, you can see that the numbers actually are slightly different. But the summary of these procedures suggests that I think you need something like 200 procedures for EOS and 60 procedures for FNA in order for a trainee to become competent. So that was generally accepted. However, new evidence has emerged to suggest that this current recommended numbers for EOS as well as EOS FNA actually underestimate the volume of procedures required in order for a trainee to achieve competency. And the studies mostly came from the Varni's group, where it shows, as shown here, the numbers are much higher. So this is where I think I'm going to go to the next particular topic. I'd like to share with you that I think we need a more objective way to assess competency of a trainee during workshop or during his or her training program. And to assess competency objectively, we need to consider two issues. One is the so-called quality indicators. The other one is how do we actually, is there a tool for us to assess this sort of quality of performance? So why quality is important? We know that quantity alone is not sufficient. So in this respect, if you look at quality indicators, yes, indeed, I think colonoscopy and ERCP have already got fairly well established quality indicators, such as cecal intubation rate, as well as papillary deep cannulation rate. And these have been used to assess trainee competency. Unfortunately, US has no such quality indicator to date. ACG did come up with 23 quality indicators. However, these are actually intended for experienced endosonographers in their daily practice, and it's not actually meant for evaluating trainees in US training. So this is where I'm going to come to the next particular issue, which is about assessment tool. So assessment tools, again, I think if you look at the existing tools for assessing a competency in endoscopies, I think we do have, the various tools listed here. But these tools are all designed for OGD and colonoscopy and are not specifically designed for US. So to date also, we do not have clear recommendation on what parameters we should be including in our assessment of trainees' performance when they undergo the US training. So this is where we need actually prospective data to help guide us in our development of evidence-based training guidelines. So what data do we have now? So I'd like to actually share with you the sort of data, I think, which have been published on the different, EUS procedures ranging from EUS up to interventional EUS, and in two settings. So one setting is the workshop setting, which we commonly conduct workshops. And the other one, obviously, is we take in a lot of trainees under our wing in a formal training program. Again, I think we need to have certain objective kind of tools for us to assess how the trainees perform and develop in their training program. So firstly, on EUS alone without FNA. So I think a number of years ago, we did actually look at these issues among our workshops conducted by the Asian EUS group. So we try to assess our trainees before and after the sort of so-called short-term workshops. Firstly, we look at the knowledge. Okay, how good are they after they have entered our workshops? So we use a questionnaire before and after the workshop, and we did show that I think the trainees improve their knowledge after attending our workshops in different domains, as shown here. And also we assess their skills when they practice on simulators, as shown here. This is actually video before they were taught about how to use a simulator. And the second one is actually after they have actually attended the training. You can see that there was a clear improvement in their performance of EUS based on these videos. So objectively, actually, we try to assess this particular issue using the Ikuma model. So how we define, I think, competency is based upon the success of the trainees in locating specific structure within 2 minutes. So we did show that the trainees actually improved from something like 20 to 40% of their success in locating all these different structures to something like 80% after the training program. So further than that, I think, yes, other groups also, I think, did look at this issue of assessing competency, and this is actually in training program setting, not in the workshop setting as I showed previously. And they define the competency as T-staging accuracy, okay? And 3 studies were done. And they sort of came to roughly the same conclusion that the trainees actually became competent in staging accuracy after something like 65 to 231 EUS procedures. So moving on, I'd like to touch a bit about the issue of competency in EUS FNA in the training setting. So firstly, on workshop setting, and this actually FNA competency issue was actually studied by a Chinese group, okay, in their particular workshop. So where they use a swine model, and they also use this sort of empty shelves of iodine seeds to create targets for FNA. in the caudate lobe of the liver of the soy model. So their training workshops included a two-stage hands-on training, which was 1 week apart, and each trainee was asked to perform 6 FNAs. So a total of 10 trainees participated in this particular study, and the results are shown here. So what they found is that the trainees improved in 3 markers of competency: procedure time, success rate in FNA, as well as accuracy of their FNA. The results are shown here. So I think they did actually show competency in a certain way during and after their workshop training. So I think in terms of training program setting, again, the FNA was also assessed by 3 different groups, and they define markers of competency as either adequacy of the specimens or the diagnostic accuracy or sensitivity of the FNA. So I think they also show that competency in the adequacy of specimen and accuracy of FNA was achieved over a range of something like 30 to 40 FNA procedures. So moving on, I think more recently, the competency was objectively studied and also assessed in a more comprehensive manner, because I think people realize that you need to actually expand it to include both EUS as well as FNA. So this was studied very extensively by Wani's group. So they came up with this so-called objective standardized assessment tool called TZAT, which stands for the EUS Skills Assessment Tool. And in that particular tool, a number of technical as well as cognitive aspects were actually assessed, including identifying lesions, TNM staging, subepithelial wall layer, as well as EUS FNA. And since then, ASGE has adopted this particular tool and has also validated that this tool was actually good in assessing both the technical as well as the cognitive competency in a continuous fashion. And since then, the tool has been used in both the workshop setting as well as in training program setting. So I just want to actually highlight this particular study where this particular group from China used the TZAT tool to actually assess trainees' competency in a workshop setting. So their training program comprised about 4 stages, and each stage was of 2 days duration, 4 months apart. And the trainees were asked to perform the different EUS procedures on simulators as well as patients. If you look at this particular diagram, you can see that the test was conducted either once or twice during each of the 4 stages, as shown here. That's the stage 3 and stage 4. And then the 9 trainees participated in this particular study, and at each stage, the trainees were graded by their trainers. So I think this graph shows that I think in both the technical as well as the cognitive aspects, I think competency was actually achieved and also improved progressively from stage 1 up to stage 4 in this particular training workshop using the TZAT tool. So the TZAT tool was also further assessed, I think, in the training program setting by Wani group. Okay, so the Wani's group actually defined failure rates of less than 20% as actually competency. By using this particular definition, they found that actually, if you look at the number of procedures, okay, between 200 to something like 300 procedures, only 4 actually out of the 17 trainees actually achieved this so-called threshold number of procedures. Okay, so they were not actually, only 4 were considered competent if you just look at numbers alone. So this is why I think the authors concluded that the number of procedures required to achieve competency was actually far greater higher than the current ASGE recommendations. So majority of trainees were actually not considered competent. If you just look at procedures of between 200 to 300 US procedures. So finally, I'd like to just finish off this particular sharing sessions by touching upon, I think, intervention EUS, which everybody knows is now becoming very popular and also very important in our daily EUS practice. So the sad news is, I think, in assessing competency or intervention in EUS, currently we do not have either the quality indicators nor the assessment tools. So I think what is then a good tool to standardize assessment or competency? I believe that currently TZEC is probably the best tool for us to do that, okay, for both EUS as well as EUS FNA. And finally, as EUS training continues to become interventional, I think we do need to come up with a more objective way of assessing competency in EUS or in interventional EUS. So with that, I'd like to thank you all for your attention, and also like to actually thank you, the India EUS Summit, for this privilege to share with you what I know about the assessment of EUS training. Thank you very much again.
Thank you, Dr. Lawrence. My apologies, during the introduction, I just got a call from the department.
No problem.
I'd just like to start off the discussion with two questions. So when we initially started learning EUS, maybe around, say, 14, 15 years or 12 years back, we had a software which was called EUS Meets Voxelman. So this was something which was directed at special anatomical orientation when you are doing a EUS, and so you get a EUS picture and you get a picture of exactly how the anatomy digitally looks like. So I think for the trainees, when they start off with, the most important thing is to identify the anatomical landmarks, and when you're rotating your endoscope, it shows you exactly what direction you are giving. So are there any tools at present that you would recommend trainees who are just starting off to have this kind of anatomical spatial orientation, because that is extremely important for the ones who are beginning EUS?
Yes. No, I think certainly, I think you're referring more to the different methods to train the particular training. I think, yes, we can certainly use simulators, models, computer simulation, and so forth. So I think in terms of I think the current challenge is more in terms of assessment, because we tend to not to pay as much attention to assessment, whether a trainee truly benefit from the training in a particular workshop setting. So that's where I think I'm trying to highlight the challenges, the issues about assessment of competency. And this has to be a bit more, I believe, to be improved during many of the workshops. I think more attention should be paid upon how we assess whether trainees gain, improve, and so forth. Harder to do in a short term, I think, workshop setting, 2 days. But I think for trainees who are going through your training program, I think there's a need to come up with your own assessment tools.
Objective assessment for
exactly.
Yeah. Thank you. The second question I had was, EUS is now going through three kind of phases, where you have a diagnostic EUS, you have EUS with tissue acquisition, and then you have more advanced procedures like an EUS guided biliary or a pancreatic drainage. So what would your recommendation be in terms of those who want to proceed to the third stage, where biliary drainage or pancreatic ductal drainages? So do you recommend that those who are doing, say, for example, a certain number of, one would say, a pseudocyst drainage, for example, that may be a stepping stone towards more advanced procedures? So are there some studies or assessments to see how many of these interventions, not the FNA or not the FNB, but more directed therapeutic procedures like pseudocyst drainages or cyst ablation, so things like that, which can take you forward to a biliary drainage scenario?
This has not been accessed, but in simple terms, I think I didn't have time to share with you. Certainly, I think there are certain criteria which we employ to choose the correct trainee. So number one is you need to pick the correct trainee to do intervention. It's been shown before, that part. And then after having chosen the correct trainee, meaning that those trainees who have achieved, I think, competency in US, certain numbers, and clearly have good hand, and then also having some skills in ERCP is an advantage. So I think having sorted out, then I think we will go through the interventional US training, which has higher risk, obviously. So I think we generally progress through what we call, I think initially it's observed, then they practice on simulators, and then after that, they have to do training in a more, I think, high volume centers. I think that has also been studied before. But what has not been studied is how do we assess competency in intervention at US? That has not been studied. But in general, I think it's thought to be at least 20 procedures are required in pseudocyst drainage, because that's probably the easiest one, okay? The least risky. Before one can be, what they show is using threshold numbers. I think the complication drop and then the success rate goes up after about 20 procedures, intervention for a trainee. And after that, you can mention about, I think, going on to biliary drainage, because I think biliary drainage, the issue is obviously bar peritonitis, which is higher than the traditional ERCP, although I think it's lower in terms of pancreatitis. Yeah.
Yeah. Thank you, Dr. Lawrence. Any other questions from my co-chairpersons?
Just one to Dr. Lawrence, if you allow.
Sure, Vikram.
Dr. Lawrence, just very briefly, your message for maybe the senior endoscopists who would like to start EUS in the later part of their career. So how much time to devote? And obviously, when do we say we are obviously very sort of reverence for the senior people, but how do we say that they are now competent? They have been our bosses once.
So I guess I've been to different centers, I think, over the years, and I have learned a few things. I think certainly is number one is to choose the correct trainee. Unfortunately, not everyone is suitable. Assuming that the trainee has a knack for doing the thing, I think they do need to go through the usual thing. Meaning that they have to go through certain observation and then practice, and then after that they do it on the thing. I think in high volume centers like in India, there should not be an issue. The issue is obviously, I think, in low volume center, that will be the issue. That's where I think initial exposure in the workshop setting may be beneficial, and that's a value. I think this sort of workshop like India EUS Summit will be helpful, as well as the AAG Summit will be helpful. So I think for the senior ones, I think we do actually within AAG, we do actually have encountered this issue as yours are, because certain countries, the developing countries, I think whether we actually even go down to help them, and then we kind of discuss what is the infrastructure and so forth, and what is the support system. Because even if you get trained, do you have enough supervision to go back and do it competently and so forth in your own center? So I think we do have to go through this, all this assessment. If we feel that this is okay, I think sometimes EAG, say for instance, we say that we have to go and open up a new center in Bangladesh doing workshops, then we have to assess all these factors which you mentioned. Even though there's no junior trainee, you have to start with the senior trainees. So all these factors come into the thing, is whether their local hospital has the enough, I think, numbers to sustain their competency, have enough supervision given to them after the initial training. Okay, so this is again the same factors when they come to your center, for instance, before you send them back to their own center, whether they are able to sustain their competency.
Dr. Zubin, Dr. Rajesh.
Thank you, Professor Lorenzo. I think we can move on to the next.
Thanks a lot. So, best wishes.
Thank you, and thank you, Dr. Vikram, Dr. Lalit, for
Thank you, Rajesh.
chairing the session, and we can move on to the live after 10 minutes. Thank you.
Thank you.